I'm Kristin Comella. I'm the Chief Science Officer of US Stem Cell. And really, the point of my talk today is to raise awareness about some of the things that we're doing in clinic right now for patients. And I suppose some of the things that I'm going to talk about are a bit controversial and certainly in the regulatory gray zone. And I really appreciated some of the talks from the last session kind of discussing the importance of remembering that it's the patient that we need to think about and the patient that we need to worry about. So in the interest of the patient, some of the things that I'm going to be discussing, we would like to see officially as legal according to the FDA. And certainly a lot of the things that we do at our clinic are in that regulatory gray zone. So we'll show some of the work that we've done and some of the work that we've had to take outside the country because of limitations here in the States. So just as a quick reminder, US Stem Cell is a publicly traded company, so I do have to show you the SEC forward-looking statements. And also US Stem Cell is formerly known as Bioheart, was recently a name change. So the whole concept of regenerative medicine is to harness your body's own healing potential and reverse some of the effects associated with degenerating tissues. And so when you think about this, you can utilize stem cells in many different diseases because they have to do with tissues that have become degenerated in some way or that lack the ability to heal themselves because enough stem cells are not going to that area. So this is what we've really focused on at our company. And I've been 2 weeks on this terrible cold sinus thing, so I'm going to have to keep drinking water. And I don't know, at some point we may have to up my mic. So at US Stem Cell, we've really broken our company into 4 different divisions. And the first division has focused on utilizing products that go through the typical FDA procedure. So this is where Bioheart was originally founded. And we were founded in 1999, and the concept was that we could utilize stem cells from muscle tissue and use them to reverse some of the effects of heart disease, and that these cells could be implanted into the heart and possibly grow new muscle tissue and improve the functionality of the heart. So this is a product that has to go through the IND process because it is regulated as a 351 product, and so it requires phase 1, 2, and 3 clinical trials. So we spent about $120 million trying to get this through the FDA process. We made it to phase 3 and ran out of money. So this is the dilemma with this process because at this point we're already a publicly traded company, so most venture capital firms are not going to be interested in putting money in because we're not early enough. We can't get money from the government because we are a company for profit. So who's going to fund this trial? So instead of being able to do this trial, it's sitting there shelved. And it's really a waste because the patients have responded very well that were part of our phase 1 and phase 2 and phase 2-3 study. And we have an approved FDA phase 3 trial that we can't do. So we can't bring these therapies forward because there's no platform for financing for companies in our boat. And I think you're going to see a lot of products that are failing because of this, because of the lack of environment for funding for bringing these therapies forward. So just to give you an idea, and also, by the way, we do also have a phase 1 approved for a combined cell and gene therapy product, which again could be a wonderful product for heart failure patients, but lack of funding is what's preventing these therapies from moving forward. Bringing a product through the traditional drug process can cost billions of dollars, and small cell therapy companies don't have the money to do it. We just can't. We can't compete in the big pharma world. So in our phase 2-3 study, this was a double-blind placebo-controlled trial, our endpoint was exercise capacity. And the patients that had received treatment walked about 100 meters further than the control, placebo-controlled patients. So patients were walking an additional football field length after having received this therapy. So if this doesn't convince people that we need to put funding into these type of products, I don't know what will. Just to put this into perspective, biventricular pacing was approved by the FDA with only a 20-meter differential. So we're looking at something that's 5 times greater than the gold standard. But again, it's lack of funding, not lack of efficacy, that doesn't bring these therapies forward. So what we've done is branched out into other indications, and also what became very exhausting for me and really sad is that we would have patients calling us all the time please help, my father has heart failure, or my husband, or my wife, and we want to do stem cells, we want to try it, we'll do anything, we want to try it. Well, A, I might not have trials that I'm enrolling in. B, you may not qualify. C, it's probably placebo-controlled, and you may not even get the product. So this is something that's not fair to do to patients who are wanting to try something, who are willing and able to give informed consent, and who don't have time to wait for our double-blind placebo-controlled trials to be completed and for their insurance to cover it. They don't have the luxury of time. They're sick right now, and they need our help right now. So what we started saying is, why don't we do one of two things? Let's look at countries where the regulatory process is different, where we can bring therapies forward, where we can offer these therapies. We know they work. We've had some good success. Why not start bringing it to patients, which is really the reason we got into this in the first place. And the second thing is, why not start training physicians to begin offering some of these therapies? So we began this branch of our company called US Stem Cell Training. And our goal was really to bridge the gap between what happens in medical school and then once you start practicing with regards to regenerative medicine. Because there's not a lot of discussion about stem cell therapy or therapies of regenerative medicine type and how that can be incorporated into the practice. So we began offering CME courses where we can educate physicians about some of the different things that are going on, the different trials, the different types of cells, how they can be used. And the goal is to really, again, bridge that gap between medical school and then what happens in clinical practice. So these are just some images from some of the different courses that we've done. A lot of this is didactic lecture, but it's also combined with a hands-on component, learning different techniques. And what we found is that physicians from all over the world have come to these training programs, learned some of the techniques, and then applied that to their practice. And as a result, we have really built a huge database of knowledge. And we've learned a lot about some things that can work in the clinic and some things that can't. The other division that we have is vet biologics, and this is where we focus on the vet side. And the regulatory components are much easier on the vet side, so we can do a lot of things that we can't necessarily do on the human side, bringing that forward. So just to give you an idea, one of the biggest things that we work on are horses. Horses get something called laminitis. We can demonstrate improvement and substantial reduction of lameness, reduction of rapid hoof growth with increased depth of sole, and correction of the bone rotation that occurs. So this is similar to an arthritis in horses. This is from the small trial that we did for laminitis, basically demonstrating statistical significance over time, over that 180-day period. And really, there is no cure for laminitis on horses. Most of these horses, once they develop laminitis, end up lame and they're put down. So we also thought, how can we bring this to the human side? So again, training physicians and then looking at how you can apply stem cells in many different applications. And the concept is that anywhere that you have degenerating tissue, why not utilize stem cells to help repair that? And the issue is that when you have degenerating tissue, your stem cells are not traveling there in high enough numbers to help repair that damage. So what we could do is basically assist the body in its own process. Harness the cells from one area, relocate them to another area. So these are some images from our clinic. We have a fluoroscopy. We can do guided injections, discs, intrathecal. We can do many different techniques. So usually what we're doing is focusing on using adipose tissue, but we can also use bone marrow, and we can also do a lot of different techniques with platelet-rich plasma. So before I tell you about some of the details, just want to review the concept of the healing cascade. And one of the issues when we're healing is that we go into inflammation and our bodies tend to overreact. We get way too much inflammation, which is really regulated, to oversimplify it, by the white blood cells. And we don't get enough of this remodeling. And so the idea of regenerative medicine is to reduce this overinflamed state and get us into a healing state for a longer period of time before we move into scar tissue. So when you think about this, the main thing that we want to do is reduce the number of white blood cells and increase the number of stem cells that are going to be part of that population to help promote it. So because of that, we've really focused on using the adipose tissue as our preferred source. So again, I just want to remind, and I know a couple people came in late, what we're doing is certainly in that regulatory gray zone that everyone's kind of been talking about over the past couple days, and that may get decided when we go to the hearing that's going to occur in April. So some of these things that we're currently doing may not be permitted within the US, but currently there is no regulatory law that prevents them. And I think that's something that the FDA is trying to decide and trying to determine how they're going to move forward with these different types of treatment. So the good news is that fat has high amounts of stem cells, and if you compare it to bone marrow, it has a significantly higher number of mesenchymal stem cells as well as what we call adipose-derived stem cells, and also high amounts of the parasites, which we know are the precursors to the MSCs. And what's even more important is that it has low amounts of white blood cells, whereas the bone marrow tends to have much higher amounts of white cells. So if we look at it from a regulatory perspective, I think that probably bone marrow is going to continue to be allowed. So it's mostly SVF that is in this questionable zone, because bone marrow has kits that are 510K'd, so there is a regulatory pathway for getting bone marrow and PRP approved. There is no regulatory pathway for SVF. And I think this is the problem. If there were a pathway that made it simple in the way that bone marrow kits have become into play and that are being utilized, SVF could be a little bit easier regulated, and now you would see people actually going through the appropriate measures, getting validation studies, demonstrating that their kits do produce an appropriate product. And I think that's where we've kind of fallen short. We need to think about how we're doing it for bone marrow, and why would we regulate SVF in a different way than bone marrow, especially when you look at some of these numbers and you can demonstrate that SVF is preferable in every characteristic. Less white cells, more stem cells really is what you want for doing a regenerative process. So I want to talk about some of the methods that are currently being used in the clinic. So remember, these are in-clinic procedures being done by physicians. This does not represent a list of all the different stem cell trials and the therapies that are going on. So we have bone marrow concentrate. The issue is that it has very low MSCs and typically very high white blood cells. We have whole fat grafts. The issue with this is that you're often including the adipocytes as part of your population. Could create a lot of inflammation. Adipocytes tend to harbor our toxins, so not necessarily something that you want to put in a joint. Also not something that you could use IV or for some of the other indications, so really limited to orthopedics. Platelet-rich plasma, you have a lot of different types of platelet-rich plasma, so not all PRP is created equally. If you have high white blood cell counts, again, you can create a lot of inflammation. Nebulizing of cells. So this is often thought that if you nebulize the cells, you can get them into the lungs and help patients that have lung disease or COPD. And my concern about this is that once we nebulize the cells, they're rather large. They could get caught in the mucous membranes, and so maybe this isn't the best thing for putting cells into the lungs. You're much better to do an IV. The cells are going to make a first pass through the lungs anyway. You have some of the placenta amniotic tissue. Some of these are just going to be growth factors because you might be doing morcellization, so there may not be surviving stem cells in that population. And again, that's a broad statement. There's a lot of different companies doing a lot of different techniques. So what we preferably do in our clinics is to utilize platelet-rich plasma, but only with low white blood cell counts. These can be utilized in a variety of different indications: soft tissue, joints, ligaments, tendons, acute injuries, wounds. Nebulizing the PRP, allowing the different growth factors to go into the lungs. Very high in hepatocyte growth factor, been demonstrated to help produce new lung tissue. You can utilize it in eye drops, especially for dry eye. Why not? It's more natural than any other product you might put into the eye. Very good results with that. Also the stromal vascular fraction. So this is what we're obtaining from the fat tissue, the SVF. Very high in MSCs, very low in white blood cells. You can use these in a variety of different delivery indications: IV, intrathecal to gain access to the brain, or for spinal cord injuries, intra-articular, intramuscular. And then finally, culture expanded MSCs. So speaking, if there were no regulatory concerns in the US, culture expanded MSCs would make a lot of sense. Now, of course, in the US, we have those limitations. You have to be part of an IND. You have to go through the appropriate regulatory procedures. But outside the country, those same rules don't apply. And a lot of countries are essentially getting ahead of us. They're doing more research. They're treating more patients using culture expanded MSCs. They're looking at more indications. And patients are leaving the United States to seek these treatments. I have a problem with that. I think that's wrong. I think that we should be treating our patients here, and I think that we should be offering the best techniques here, and there's a lack of funding to do that here. So the other thing that I think has happened with the field, sorry, 2 days ago I was speaking nothing, so this is like the comeback voice. The other thing that has happened is that I don't know when it was decided that stem cell therapy should be one dose and done. All of our trials have been set up mostly as one dose, let's test one dose and done. I think it's highly inappropriate. Name one drug that you take one of and you're magically cured. It doesn't work like that. I think what we need to do is think about repeat dosing because we're trying to remodel tissue. We're trying to bring forward different treatments and change the course of a disease. This is going to require more than one dose. So we have to change as a field what we're thinking is the appropriate treatment when it comes to regenerative medicine, and repeat dosing makes more sense. Now the problem is there's no good regulatory environment or pathway for that. It's nearly impossible. I'm speaking from a company that has gone through the whole phase, getting to a phase 3. That was for one dose. If we wanted to repeat dose, we'd have to start over from the beginning and start doing all those trials to demonstrate safety and efficacy. So very challenging regulatory environment because it's not set up appropriately for those type of therapies. So to share with you some of the things that we've done in the clinic, PRP. So again, the whole concept behind this is to utilize your platelets, which have a lot of different growth factors and proteins associated with them that can enhance this healing cascade and really enhance recruitment of other cells to the area. So in case you didn't believe me that PRP will help healing, we got one of our doctors to agree to do a split face, and we did a technique called CO2 laser resurfacing. So it basically makes the skin raw. And then on half of the face, we did PRP, and on half of the face, we did no PRP. So this is the no PRP face, and this is the PRP face. So you can see how much better in just 1 week time the healing was just by applying PRP. So think about how you can utilize PRP in so many different indications. Wound healing. We should be giving PRP to every patient that comes in with a wound. Let's heal it up. Every patient that comes in with a burn, they should be getting PRP. Why aren't we doing this? This should be standard of care. It's time. PRP has been around for decades. Why are we waiting? What are we waiting for? How many patients have to be done until we say, okay, this is an appropriate procedure and it is standard of care? Same-day stem cell process. So what we basically do when we're collecting the fat tissue is a mini lipoaspirate procedure. So this is done with just local anesthesia. We make an incision that's about the size of my pinky nail. We put numbing solution just below the skin. The patient stays awake for the whole process. And then we can process that fat to obtain what we call the stromal vascular fraction. We are doing enzyme digestion. I know there is a lot of question as to whether or not enzyme digestion is considered more than minimal manipulation. But currently what we're performing under is same surgical procedure. So if the FDA chooses to redefine what same surgical procedure is in these new guidance documents and with the hearing, this could change whether or not we're permitted to do this. But for now, we've had no issue. We're aware of thousands of physicians currently doing this in their practice. We're aware of more than 10,000 patients that have been treated using this therapy. And then the cells can be collected and then reintroduced to the patient. So I want to share with you just some of the results and some of the different things that we've done either ourselves at our clinic or with partners that have been trained by us that currently do this. So you can use this in aesthetics. This is something called a stem cell facelift. This is a little hard to see because of the light, but basically improvement in the skin because you have increased volume, but the stem cells themselves will help with an angiogenic process and create this youthful glow. You can see an improvement in the skin glow and also the correction of asymmetry here. This is a 6-month time difference, a very natural appearance. You can also use this in hair loss. You can use PRP in hair loss. Applying PRP to the surface, you can do subdermal injections. You can also do microneedling and apply it topically to allow the PRP and or the stem cells to get in. And it really can delay this hair loss. We do quite a bit in orthopedics. This is an example of a patient with osteochondritis, and you can see the bone lesion here in the elbow. This is actually a famous picture, not famous to me, but famous to some people. And what we demonstrated was with just an intra-articular injection complete resolution. And so somebody whose career was about to be over is now back pitching. This is a big deal. And again, this goes back to a patient's decision, informed consent, and their decision to try something that is not the standard of care. And when did it become that we couldn't make our own decisions about what we do to our body? Osteoarthritis, this is a typical knee patient. You can see the decreased joint space and after intra-articular injection, increased space, lack of pain. Peripheral neuropathy, we're typically doing intramuscular delivery, and you can see the reduction of the redness here. This is a 3-month delay. And you can do this with just PRP, or you can do it with the SVF. These are 3 different knee patients that were recently published in the large paper with 1,100 patients for SVF and PRP. This is an example of a grade 3 OA, and you can see kissing bone right here. After intra-articular injection, 12 months post, increased joint space. This is a defect in loose flap that's shown here, 6 months after, reintegration of that flap. And then finally, bone lesion that's present right here, and again, smooth chondral layer 18 months after. In this trial, 95% of the patients demonstrated improvement in their arthritis. No, go ahead.
I'll wait.
No, it's okay, go ahead.
Was this just an intra-articular injection, or did it target a specific structure?
Intra-articular, mostly knees. In this paper, yeah, intra-articular. Yeah, so to your point, you can use ultrasound and guide it directly into specific tendons or ligaments that have issues, but this one was just intra-articular. And 95% of these patients showed improvement. Name a drug or something that you're currently injecting into the knee that would do that. Colleen?
Just the SVF.
SVF plus PRP. Yeah, so this was recently published. The publication's on the bottom. And I'll share my slides with you guys. I'll give my email at the end so you can have my slides. So what we typically do is a 22 or 23 gauge, 1.5. But I don't know what they used in their study. So I'll show you this video, and many of you may have already seen this, but this is a typical patient that we see on the vet side. Like I said before, on the vet side we can do a lot more stuff than we can do on the human side. So this is arthritis, 12-year-old patient, pretty severe, has a hard time getting around, can't really go up the steps very well, certainly would not go up the steps unless led by leash. This is 3 weeks post-injection. You can see a lot more mobile. Less inflammation means less pain. So the dog can walk better. Going up the stairs on his own.
Where did you inject?
2 hips and a shoulder, intra-articular. So that initial response is typically seen in the first few weeks, and it's just because of the anti-inflammatory. This is about 2 months post, like a different dog.
Also lost weight.
Lost weight because he can exercise, because it's not as painful. Able to go on walks again. You can see here going on a jog with his owner. If there were sound, you can hear the owner saying, "Amazing, amazing, come on, this is amazing. Why wouldn't you do this for yourself? If your knee hurts, why wouldn't you do this? I've done stem cells in my knee twice."
That was fat plus PRP.
Fat plus PRP. SVF, not whole fat, SVF. Yeah. So we've done a study with Dr. Silbert out of Indiana for degenerative disc disease, and he presented these results at the Academy of Regenerative Practices, which happened in June. And if you want the full slide set from his program, I can provide that as well. But basically what he showed is that there was statistically significant improvement in flexion. He also looked at a variety of different quality of life parameters and across-the-board improvement. So he did 10 patients in this trial. Every single one of them demonstrated improvement. Now, I get that it's a small study, but that's pretty amazing Think about a disc fusion, not very successful, extremely expensive, severe adverse event rate, 7%. That's a high number. So no adverse events reported in any of these studies, and pretty good outcomes. So I think very exciting that there's an opportunity to do things, especially for back patients, that have very limited options. There's not a lot available for these type of patients. We've done quite a bit in COPD. We worked originally with a group in Mexico to bring some of these therapies forward, and since that time we've done a lot more patients in the States. So patients will present to us from all over. So I don't know if any of you have known someone who's had COPD, but it's a really awful disease. You're essentially drowning until you die. You cannot breathe. So these patients would really give anything just to have a little bit of relief. So what we demonstrated is that we could improve their quality of life in the St. George Respiratory. We could also improve their exercise capacity. Patients that have come with COPD to receive treatment have demonstrated strong anecdotal improvements. Now, the issue is that, of course, we don't have double-blind placebo-controlled trials, but I put it back to you, who's going to pay for that? Where can we get the money for that? Because I would love to do that study. I'll do it tomorrow. I've got patients lined up out the door that would love to try these treatments. There's just a lack of funding. So in the meantime, does it make sense to prevent those patients from trying these therapies if they're able and willing to give informed consent? I think it's almost criminal not to allow them to try it. We've also done quite a bit in the heart, and we recently released results from what we called the ANGEL trial. This was a small phase 1. It was just with 5 patients. We do an implantation directly into the heart using a catheter, which is guided by fluoroscopy. And what we demonstrated was a statistically significant improvement in ejection fraction. We also demonstrated a statistically significant improvement in exercise capacity. And again, just to put this into perspective, there's not many drugs on the market that can give you these kind of results. It's a small study, it's 5 patients, but if this doesn't convince people that we need to get funding to the field to move these therapies forward, I don't know what will. So sometimes we have setbacks. We have been doing some patients for dry macular degeneration. We treated about 14 patients. Preliminary data was showing some subjective improvements in patients. However, we've had now 2 possible adverse events, and as a result, we've suspended all treatment of dry macular degeneration. We were doing an intravitreal approach directly into the eye, but we can't let 2 adverse events out of more than 4,000 patients derail the whole program. I think it would be a mistake. There's going to be setbacks. There's going to be therapies that don't work. There's going to be times when our delivery approach isn't appropriate, and we have to rethink it, and we have to rethink how we do that. This is why we do very slowly. We move slowly, especially when we move into a new indication. The question would be here is, why did we have 12 patients that had no adverse events and then 2 that did? And is that a result of the actual injection or of the cells? These are all questions that we're investigating and trying to get answers to. I want to share with you a couple other cases. This was a really interesting case that we actually did in South Africa. We have a facility there that we work with, and what we did was the SVF plus PRP for a patient who had had a cancer and had received radiation from about the nose down to the chest. And as a result, all of his salivary glands had been destroyed. So he was no longer able to produce saliva. He had very severe dry mouth, which meant that he wasn't able to taste, sleep, he couldn't speak, and his overall quality of life was such that he was suicidal and depressed. And when he presented to the clinic in South Africa, he said, "This is my last hope. Either this works or I'm going to kill myself." That was the plan. So again, why would we not try this for somebody? It would not make sense not to. So what we did was do a direct injection into the glands by ultrasound, and what we demonstrated is the glands actually doubled in size post-treatment. And what was nice, because we're in South Africa, we can do culture expansion of the cells and do repeat dosing for him using his own MSCs, come back and do multiple doses, and guess what? He's now producing saliva. So this is really life-altering and changing, and something that could really change the course for so many patients who are out there with very little options. These are the ultrasound images, and you can see here, this is the 2.18, and then post just one treatment, 3.17, 1.95 to 3.11, And then on the other side, 1.58 to 2.65 and 0.83 to 2.7. So since that time, he's gotten 2 more injections. So the hope is that we can actually recover those glands back to normal functioning glands, and he can produce saliva and live a happy, normal life. So just in case you didn't believe me that stem cells could be healing in nature, I got some of my friends and family to let me burn their arms and then put stem cells on their arms. This is the kind of experiments I have a budget for. So what we did is we made 3 burns, and then we did 3 groups. One that was just a control, one where we did PRP alone, and then one where we did PRP plus stem cells. And what we demonstrated is that we could reduce the healing time quite a bit by just adding PRP. And then by adding PRP plus stem cells, we could reduce the healing time in half. So again, think about how you can apply this to wound healing, to burns. Many victims, burn victims who have really no choice and debilitating pain and injured skin. We did the first case that we know of for radiation necrosis, and this patient, again, had a cancer that was removed, but then received so much radiation that the tissue had become necrotic, and as a result, she developed this non-healing wound. So as a last-ditch effort, what we did was inject the cells in and around the wound in the hopes of healing this tissue. And this was just with one treatment. We were able to have complete resolution of that wound. And if you take a look at the before and after angio, you could see the lack of blood flow before on that right leg, and post completely normal blood flow in both legs. In fact, the radiologist reported that there was identical blood flow in both the treated and controlled. This is a patient that we treated recently who had lost his limb because he was working on his fingers because he was working on his motorcycle, and his hands got caught in the chain. And as a result, he was left with these 2 fingers that had really kind of gangrenous wounds. And at this point, he was scheduled for another amputation surgery because they were not healing. So our main goal when he presented to us was to just prevent further amputation. So we injected SVF plus PRP in the hopes of preventing that amputation. This was on a Friday. When he presented to surgery on a Tuesday, the surgeon canceled it and said, "This looks like it's healing." At 3 weeks, his middle finger nail began to grow back. By 6 weeks, you can see the nail was almost fully formed. And over a 6-month time period, he gained a full centimeter. We were doing repeat dosing on this patient, so we were able to gain some length on his finger. And I think the whole concept of regeneration is that you're in this state of regeneration for a short period of time, and then you move into scar tissue. So if we can prevent you from moving into scar tissue and keep you in regeneration just by modulating and putting stem cells there, we could potentially prevent the lack of the limb growing back because we're preventing the scar tissue. So this is, I think, a really interesting concept. And if you think about a lizard that loses its tail, it takes 2 years to grow back a small tail. So we could potentially grow limbs back just by keeping them in this regenerative state. We recently published some results on traumatic brain injury. So we've done 5 patients that we're reporting on out of this clinic, and have had some really interesting results. We're doing an intrathecal lumbar delivery of SVF, and then followed by repeat injection of culture expanded MSCs. And the first patient has just reached the 12-month follow-up. When she presented to us, she was not able to walk, and she also had a very difficult time speaking. The only thing she could say was yes and no, and a very deliberate yes or no, just to get those words out. And so when she came back around the 3-month time period, came in speaking full sentences, walked in, and told me about the day she got injured. By the way, when she presented to us, it was 2 years post-injury. And the reason she presented is because she had finished her treatments. What the doctors had told her is, that's all we can do for you, and most likely at the 2-year time point, you've recovered any recovery that you're going to have. So figure out your life. And she had 2 small children, and she just thought that's not acceptable. And what she said to me is, me with my half brain had to go into the internet and try and come up with a new plan, which turned out involved stem cells, So why are we not presenting these as options to patients that really have no other choice? Living her life the way she was not going to be a choice. That was not going to be an option. That was not going to be acceptable. A couple other patients, just early progress being tracked, but a few patients of note. 2 of the patients have gone from wheelchair to walking with assistance. 1 patient has recovered short-term memory. So very exciting. I mean, these are injuries in the brain, and why wouldn't stem cells be able to go there and help repair some of those injuries? I think it makes sense. So the last example I want to give you is one of spinal cord injury. We've done about 5 patients with spinal cord injury. Some of these patients have recovered bladder function, which is a big deal. Most of these patients are getting a lumbar delivery of SVF followed by repeat injection of culture expanded MSCs. So again, keep in mind when we do the injection of the culture expanded MSCs, there's a regulatory component to that, so we have to do those outside the country. But the SVF procedures can be done here in the States for now. And this patient presented to us 2 years post-injury, so pretty much had recovered what he was going to recover. No movement from about the chest down, limited movement of his hands. And his mom said, when she came to us, said, "I need your help because every day my son comes to me and asks me to kill him because he doesn't want to live like this. And so I have to make a decision as to what am I going to do? Do I have to kill my own child? Do I have to kill myself after? Do I have to go to jail?" So we want more options. We want to try something else. We are willing to give consent. We want to try something. So what happened around the 8th or so dose is that he began recovering function of his legs. Sorry, this is going. He's not walking uphill. He's just walking on a flat surface. But anyway, you can see he's recovered function of his legs, and he can now move his legs. This didn't happen after 1 dose. This happened after 8 doses. So again, this concept of one and done is really misleading. And if we had done 1 dose for this patient, we might have said, oh, stem cells don't work for spinal cord injury. And that's a mistake. We really have to figure out the appropriate dosing parameters and how to get the appropriate treatments to these patients. Let's talk a little bit about the safety. So far, we've trained over 600 physicians in our training programs. We've treated more than 4,000 cases for various indications. Delivery might include IV, intrathecal, intramuscular, intraarticular, intravitreal. And as far as safety issues, we've had 1 spinal headache from an intrathecal injection, completely resolved after 24 hours with Tylenol codeine. Several patients have reported headache at the time of the IV injection with an elevated pulse or blood pressure, typically resolves in 15 minutes. Nothing more severe than that. No additional treatment was required. We had 1 skin infection at the site of liposuction. This patient had traveled from Texas to Florida, and then drove home for 2 days without showering, and then decided they were itchy, so started taking bubble baths, and of course developed some infection at the point of insertion. So resolved with just antibiotics and completely fine. We've had the 2 possible complications from the intravitreal injections. As a result, we're suspending all eye treatments, and 0 patient deaths. 0, not 1, in more than 4,000 cases done. Show me a profile from any surgery procedure or from any drug out there that has 0 deaths. There isn't one. The safety profile is strong. I think that this is something that we really need to consider making part of the standard medical care and allowing patients to make a decision whether they want to use this as part of their therapy or not, and making that informed decision. Regenerative medicine is here to stay. It's continuously growing, especially for these in-clinic procedures. There's an increased demand for natural therapies with great clinical benefits without the side effects. There's also an increased demand for therapies that are less invasive and less expensive than surgery, and more conditions are being successfully treated with this type of therapy. We as a field have an obligation to bring these therapies forward safely and rapidly. Patients have the right to make informed consent decisions to use these alternative treatments, and we need more funding toward actual patient treatments so that patients can get these therapies that their insurance won't cover. So I do have time. I want to take questions, and also I want to share with you my email address. We do a free journal club and webinar series, and we have all of it recorded, so if you send me an email, I'll send you a link to the journal clubs. Also want to remind you that the Academy of Regenerative Practices Conference is coming up in February. It's in Fort Lauderdale, so especially if you live up north, come down to Florida where it's warm. It's February 5th through 7th, and this is the website for that, regenerativeacademy.com. Please register. So at this time, I'll take any questions. Yeah, I do think so. And for us, the first step was at least getting a CME accredited program, but eventually I think it should develop into a whole specialty where physicians only offer that. So I know there are a couple groups that have discussed adding a fellowship or doing something like that. I think we really need it. It would make sense. So maybe it's something that Academy of Regenerative Practices can focus on, because that conference is really focused on the clinical aspect, bringing these therapies to patients, the in-clinic type procedures, and it makes sense to offer that for physicians. So I guess if the decision is in a guidance document may not be legally enforceable, so it would require a change in the law, and I think it would require some sort of a court case for the FDA to really demonstrate their jurisdiction over it. I think many groups will continue as is unless issued a cease and desist. That's most likely what we would do, continue as is unless we're issued a cease and desist. So if any group is going to get the cease and desist, it's probably us, because they want to make an example of us, and knowing that we've trained so many physicians, at that point we have to stop. Then we'll take it offshore. I just don't think that, knowing what we know, it would be unethical for us not to keep offering this to patients. So it would be very unfortunate if the FDA takes that stance. And I would like to encourage all of you to consider getting involved and make a comment on the regulations and on the guidance documents, saying that we need these treatments. You never know when you yourself are going to need them or someone you love needs them. My father happened to be one of those people, and this was before we were getting involved. He had a heart attack, and at the time there were a couple trials going on for heart attacks. It was with Osiris and something else. Well, he didn't qualify for the trial, so he wasn't going to get stem cells. Well, knowing what I know, I was like, no, you have to get stem cells. You're going to be dead in 3 years. You're going to get congestive heart failure and you'll be gone. That's not acceptable. I don't accept that. So we did get him stem cells. We had to take him outside the country to do it. Now for a patient like that, we would typically do that in the US. The challenge is that so many of the patients that we see can't travel outside the country. They can't go on a plane because they're too ill, they're in a wheelchair, they're on oxygen. So that's not a choice. That's not an option for them. So limiting those patients, that's what should be against the law.
What was the clinical recovery outlook?
He's doing great. Yeah, he's now 7 years post-heart attack. His heart function was almost fully recovered. We got the stem cells right away. And by the way, we've done stem cells in both his knees and both his ankles. He was told 5 years ago he needed a total joint replacement. Doing great. So the benefit of bringing some of this stuff to the US is we've been able to bring the prices down. Patients don't have to travel as far, so it makes it more reasonable. Treatments are starting as low as $3,000. That was unrealistic 5 years ago. Right, so bone marrow is just centrifuging, but the main issue is that bone marrow and blood products got grandfathered in. So they were part of regulations that pre-existed the 1271s, and so as a result, there is this pathway to commercialization, which is called the 510K process, because there's pre-existing technology. Bone marrow has been around since the 60s, so there was pre-existing technology to go off of. There's no pre-existing technology for the fat, so there is no easy pathway, enzyme or not, and there are plenty of methods to get SVF without an enzyme digestion. Enzyme just happens to be the best method, but you can do, a mechanical digestion. So the FDA is still saying that no, they're not going to allow that, according to the new guidance document. Now, that kind of goes back to, will they be able to legally enforce it? I view it something like this. Remember when marijuana became legal in California, and the FDA would go in and shut down one clinic, and then a clinic would open across the street, and then they'd shut that one down, and then 2 more would open over here, and eventually the FDA was like, all right, never mind. And they gave up, and they stopped shutting them down. I think we're kind of to that point. Like, there's already so many clinics doing this. Open the magazine on your flight home. Stem cells for your knee. Read your newspaper. Look online. Google stem cell clinic right now when you go to your computers. You'll find so many clinics that are already doing this. It's too far gone. I just don't think the FDA can shove it back in. Yeah, so repeat dosing becomes even more critical for those patients. Most of the patients that present to us are the extreme cases that have tried everything. So this is their last-ditch effort.
Is anybody using intravenous for widespread musculoskeletal pain like
Just-
the fibromyalgia type syndrome?
Yeah, I mean, I think there's a debate as to what is fibromyalgia, but yes, we've had some fibromyalgia patients, but a lot of times a fibromyalgia patient is also like an autoimmune patient, and those patients tend to respond really well.
You mean they have a defined
Autoimmune, yeah.
disorder?
Yeah, so like rheumatoid or,
Yeah.
yeah.
How about just regular old fibromyalgia? Do any of those?
I mean, there could be a psychological
Yeah,
component to that.
maybe not. I mean, there's
Yeah, we-
widespread pain and
right.
all the labs are negative.
Yeah. So those cases we'll do them, but they're a little bit more challenging for us because we're not sure what is the mechanism of action, what are we actually doing, and maybe it is a placebo effect, in which case, okay. You know, the issue was psychological to begin with, possibly, so great.
Is there anybody you haven't done? Is there anybody you said?
Everyone in this room? I don't
No, I'm saying if somebody's sort of come to you for stem cell therapy.
Oh, and we've said no thanks?
No, you're not a good
Yeah, so active cancer we won't do. If their blood work, like if they're showing active infection, their blood work's way off, we won't do them. I had a patient that was really ill, probably couldn't, not an appropriate candidate for getting the lipo. That was too dangerous, so we wouldn't do it. We've had some like really sick cardiac patients. They have to get clearance from their cardiologist to get the procedure. So those type of things. Okay.
Great overview.
Thank you guys. Appreciate you coming. I know it's late on Friday.